Hi, it's Frances. Okay, today is prostate cancer and BPH or benign prostatic hyperplasia. So they're squished into the same slides. Um, so you just want to make sure you know that they're both in there. And after the lecture, you should probably compare and contrast the two of them so that you know what you're looking for in terms of your nursing care. Especially if you need to report something that looks maybe like it could be more cancery versus something that's more well-known BPH. You're just paying attention. I'm giving you some information here that helps you make these decisions. And I will also be telling you which ones are important and which ones are more like FYI. So you should know what the prostate does, right? So the prostate function of it is to help control the urine flow, because the prostate, the way that the anatomy is that it sits under the urethra or over the urethra, and then that comes out the penis. But then it also is the spot that mixes the baby batter, for lack of a better term, but it mixes the sperm, the prostatic fluid, and the seminal fluid all together so that the sperm have, the pH balanced environment, and that pH balanced environment can actually move into the lady, and it actually keeps the environment pH balanced so that the sperm can get to the egg without the environment of the vagina, urethra, sorry, not urethra, uterus, creating a situation where it gets killed before it gets to the egg. So there's a lot of important things that happen from the prostate. And one of the things to remember is that men can continue having babies almost until they die, probably. The delivery system might not be as good as it used to be, but all of the components are still there. So different from females, which, shut down their ability to breed at some point, men continue being able to breed, which is interesting to think about when you're wondering why women are being regulated, their bodies are being regulated versus men, but that's just political, so it's neither here nor there. The significance of the prostate cancer is a lot. It's 1 in every 5 men. Remember, breast cancer was 1 in every 8 people. This is 1 in every 5 men that get it. So eventually, with age, you are at a 90% chance of getting it the older you get. That's a lot. And this is a malignant tumor of that prostate. So, these are hormone dependent usually, so androgen dependent initially. It can change, and they may become independent of it, and that's where we'll talk about hormone therapies that fail. And they're usually slow growing, but remember there is that incidence of well differentiated versus undifferentiated or poorly differentiated. Poorly or undifferentiated are going to usually grow a lot faster because everything is kind of the same. It's very homogeneous. And so it'll all grow a little bit faster, whereas well differentiated will grow slower. So we keep that in mind when we're talking about tumors. It also is one of the reasons why I think they were very aggressive about all the testing for many years, and then started to realize they were doing a little more damage with all the interventions, and that maybe we need to be pulling back a little bit on all the prophylactic testing for this. So it's something that we need to keep in mind as a society, look at our numbers, look at the science behind it. But like I had mentioned, the incidence of getting prostate cancer can increase significantly once you've turned 50 and you're continuing to get older and older and older. And then, of course, African Americans are always at a disadvantage here. And then if you have a family history of it, you might be more likely to get it. There's your genetics. High fat diet, any kind of chemicals. I don't know what chemicals, but maybe they mean things like exposures at work, stuff like that. And just so you guys know, we're going to learn about this more in depth later, but BPH is not a risk factor for prostate cancer. They're kind of different. Even though they look very similar, they're kind of different. Okay, so metastasis is usually delivered via the veins that leave the prostate. And it definitely is going to hit those bones. You remember, when things metastasize to the bones, you're going to have a lot of pain. You can do x-rays to see if you can see fractures. Remember those pathologic fractures? So you can do those x-rays to see what's going on when your patient is complaining about, pain in their pelvis or their back. And if they haven't had imaging done, you might want to advocate for them because it's important that somebody does. A lot of times lower back pain is just accepted for years and years, decades upon decades, and we just kind of push pain meds at them. But we need to make sure that our providers are at least doing some of the bare minimum diagnostic testing to make sure it's not something else. My cousin found out he had prostate cancer because his hip was hurting. And when he went in, they did all the imaging and they found out he had a fracture. And he was like, well, I didn't do anything. And so they did an MRI and they found the prostate was enlarged. So again, you follow up with these things, even if they're bedside with you, even if it's an outpatient clinic, you notice things that they're saying and you maybe report it to the providers. So here are some different things to look at where the metastasis of the prostate cancer can move into the pelvic bones and the lumbar spine. You have your black arrow indicators here, meaning like there's some calcification where there shouldn't be. Maybe things are degrading. You're probably going to get some lesions and then some calcification in the wrong spot. It's not great. So you're getting those tumors showing up. Clinical manifestations, so usually asymptomatic in the early stages, and then later goes on to look almost exactly like BPH. So the symptomology or clinical manifestations of BPH and prostate cancer are very similar. So you have your painful urination, your hesitancy, like it's hard to get going, get the stream going, dribbling, usually after the stream has finished, so it continues dribbling, having to go a lot, frequency, urgency, really needing to go, blood in the urine, urinating a lot at night, not being able to urinate, just holding on to the urine, which I don't know if you remember this from the urinary disorders, but when you're retaining urine or holding on or cannot void, it backs up through the whole system, and that's when you end up with things called hydronephrosis. Very good. I'm sure you all said it. You can get an interruption to the urinary stream. So that's another one. And then an inability to urinate, which is our emergency situation. And you can do a DRE, a digital rectal exam, and maybe fill for any kind of asymmetry or hardness in the prostate. It could help explain what's going on. And docs can do that in the outpatient situation. They can, just sit them right down. Oh, I hear what you're saying. Let me go in and just double check. But it can be difficult to bring that topic up with their patients. So as the nurses, we might also want to just make sure that we're backing up our friends and family, letting them know what are sort of the diagnostics behind investigating these issues with urination. And so they get more comfortable with the idea that this might be something I have to get during my life. So the diagnostics are, we talked about the DRE, the digital rectal exam. And look how similar it looks to like the breast tumor, the nodular, it's hard. And then with the prostate, because you're going through the rectum to do the digital exam, you're feeling as a provider, maybe someday you will be the provider, and you're realizing that one side feels different than the other. And that's the asymmetry of it. You can also see it on MRI. You could also do a blood test and get your PSA done, your prostate-specific antigen. Normal is anything below 4. And if you happen to be above 10, there's a 50% chance that the cancer is present. So, it's significant. And you have to be mindful that when you're talking to these patients, if they're getting the PSA done, that we're not doing it if they've ejaculated in the last 2 days, because you can end up getting a false positive during that time. So we have to have an open conversation. Have you ejaculated either solo or in a couple or whatever they're into? Have you ejaculated in the last 2 days? Because it will change the information that we're able to get and could make it look like you have something you don't. So you have to learn how to have those conversations with folks. It could also be BPH. The PSA can go up because BPH, and then, or inflammation in general, like maybe some kind of prostatitis. Remember, itis is inflammation. So inflammation of the prostate can also increase the PSAs. So the definitive test, however, is the biopsy. So you go in and you get actual cells from the prostate. And generally you do this with an instrument called a TRUS, a transurethral ultrasound. And usually that ultrasound can extend out and actually get some cells from the prostate. So you do the ultrasound, you figure out where you're going, and then you can actually do a needle in to see if you can get some cells from the prostate. So the truss itself is not the biopsy, it's the guiding ultrasound to make sure you're in the right spot and getting your cells from the right area, and then you put your needle in and extract your cells. And when you get those cells, you lay them out on a slide, and then we look at the Gleason scale grading system. So in this, when you lay out all the cells, you take two different cell types. If they're both ones along the whole slide, great. Then you 1+1. But if there is a 4 and a 3, you add those together. You're always using two numbers to help grade your tumor. Okay, and this is from 1 to 5. Remember, well differentiated is going to be a slower growing tumor. An undifferentiated or poorly differentiated one is going to be maybe a more aggressive, faster growing tumor. And remember T and M when you're talking about tumors and cancers. So tumor size and location for your T, nodal spread for your N, and then metastases for your M for metastasis. So then you get your number when you add your two numbers together from your two cell patterns, and that's called additive. So it's an additive score. And you can see that the lower ones are average. Then you have a moderately faster growing type tumor based on the numbers, like a 3 plus a 4 would be a 7. But if it's usually around there, I'll go over what we do. And then the higher the number, the more aggressive that tumor is projected to be. So if you have a grade 6 to 7, even though on the Gleason scale it does say like moderately fast, a 6 to 7 still can be used to determine if I'm going to do conservative therapy and I'm going to do watchful waiting, or if I'm going to be aggressive. And of course, as the patient, you have a little bit of a say, and I'll go over all the different things you can do for these, but generally conservative therapy, which we've learned over the last 10 years of being a bit more aggressive with these, yearly exams and whatnot that we're telling people to get, we're realizing that watchful waiting is not a bad thing. So once you go into conservative therapy and you're doing your watchful waiting, you're going to get a PSA every 6 months, so blood, and you have to remind them not to ejaculate for the 2 days prior to that test. And then you're going to get a biopsy again every 2 years, which is a lot for a patient. But you generally will get the biopsy sooner if the PSA has risen a little faster than what we wanted. So we keep an eye out for that. But you definitely need to know this slide. All right, so collaborative care. Let's look at the surgical therapies that our patients can get. The radical prostatectomy is where a bunch of stuff gets removed. Like you just kind of go in and scoop out a bunch of stuff. You're going to take the entire gland, your prostate. You're going to take the seminal vesicles and part of the bladder neck, where the bladder comes down and turns into the urethra. You're going to take a part of that neck. And then you're going to go in and take out some lymph nodes from the retroperitoneal area, so the back of the abdomen. And they say this is the best one to get because it will have the best prognosis. If you can scoop all that stuff out, get it out, then you can just sort of stop those cancer cells from disseminating everywhere. That was funny. And then after they get this done, they usually will have a Foley-in for a few days. They may even continuous bladder irrigation, which we talk about at the end of the lecture, but we call it CBI, or continuous bladder irrigation. They'll probably have a hospital stay. One of my brother-in-laws just had this done and actually was sent home within the same day. So I think things are changing a little bit, as long as they're a pretty healthy person otherwise. But since they're not necessarily focusing on the nerve conservation here, they might end up with incontinence and erectile dysfunction, which may be a complete turnoff for a lot of these men. It's like, nope, no, I'd rather die than, not be able to have sex, not be able to control my urination. So you really want to talk to them about risks versus benefits if they're coming to you with questions about this. And nerve sparing, we'll talk about that in a second. And how do you check for metastasis? Do you guys know? Do you know? All right, so which test do you get? You get your PET. You can get an MRI looking for metastasis, looking for tumors, that cell cluster, and CTs. So that's how you check for the spread of a cancer. All right, so prostatectomy, the surgeon figures out which way they're going to go in. Are they going to go in from, let's see, the retropubic area? So you can see where the incision will be like kind of around where the bladder is. They'll maybe go in that way, or they go in through the perineal area where they do an incision between the scrotum and the anus. So they'll figure out which one works best. The surgeon usually will go through that with you. This is a video that you guys can watch about nerve-sparing surgical procedures in the hopes that, you can maintain some function to your penis, whether it's for sex, for pleasure, or for urination. These are ways that you can kind of maintain that side of your life, which is really important for a lot of people. So it sounds silly, but it's not. Like, just like with women who got put into early menopause from the treatments for their breast cancer, it's really soul-sucking to lose that whole side of your life. Something that you maybe cherish and love doing with your partner. So we want to have these types of conversations when these people are nervous and worried about this stuff. And even with nerve-sparing surgicals, we're not guaranteeing that their erections are going to be as strong or last as long. And we have to be prepared to have those conversations because we don't want to give anyone false hope. But hopefully things work out for them, but we can't give them that false hope. They can come up with it on their own. So watch the video here and see what you think about that. Cryosurgery, this is also a video that you guys can watch about freezing cancer tissue. It's a little less success rate. And look at all the complications that one can get from that. Generally done as a second line. It can also be first line, but generally a second line if radiation fails. And we'll talk about radiation in a little while. But that's a long list of complications. So damage to the urethra, so you're having a hard time urinating. Remember those fistulas we talked about? So one goes from the rectum right into the urethra. So you might even be peeing, bowel movement, feces. Another one can do a ureterocutaneous fistula, where like urine's coming out of your skin because of a tunnel that your body made. You might have some tissue sloughing within your urethra. You might have erectile dysfunction, urinary incontinence. There's that prostatitis, that inflammation to the area. And you may also bleed. So there's a lot of downsides to this, especially with a low success rate. This may not be the thing that people want to use, but they might. You don't know. Okay, so SLO 19 is where it's asking about orchiectomy and other surgical interventions. So the orchiectomy is exactly what it sounds like. You're ectomizing those orchi. You're removing those testes because this prostate cancer is in the advanced stages. And so you're just trying to get rid of anything that can hold on to those tumor cells. And it may be done alone, or it might be done with the prostatectomy. But it does, when you take that node out, when you take those things that are part of the hormone system, you're going to reduce your circulating testosterone by a significant amount, 90%. And then you're going to put them into some kind of menopause or manopause, because you still get hot flashes if you don't have all that testosterone. You could again have erectile dysfunction, loss of libido, irritability, weight gain, loss of muscle mass, and osteoporosis. This is all big stuff for people. And their bodies will completely change once they have this. So you may need to supplement with testosterone. So you'll want to know, but this is more like a FYI. So we've talked about robotic nerve sparing surgical procedure, cryosurgery, orchiectomy, and now we're going to talk about radiation, because radiation can be done prior or after a surgery or alone. So you have your external beam radiation, which is more like, remember where we talked about you get like a little tattoo to know where you're going to concentrate your radiation, and it can help. And then you also can have your brachytherapy, which is where they're going to implant those radioactive seeds into the prostate gland. And you can get a low dose one, which will just, they'll stay in there forever, or you get a high dose one where they put it in and then take them out. Now with the low dose one where it's going to stay in there forever, you have to be very careful if you're dealing with these patients, talking to them about their sex with a partner. They should not be having sex for at least 2 weeks after having these put in, because they're pretty strong still, and you don't want to create a problem for your partner potentially. And then after the 2 weeks, it's okay to start re-engaging in sexual contact, but they're going to need to use a condom because and I think there might be a specific time frame where they need to use a condom. I don't know what it is, but these are the kind of things we have to talk to them about. And impotence is still possible with all of that, which is a bummer. And here's your brachytherapy. Remember our mammo site? This one is a prostate brachytherapy where they're just putting the needle in and then they're planting those radioactive seeds in. And if you think about it, patients have actually a lot of options, which is good. We can either take the tissue out, we can radiate the tissue, we can freeze the tissue, or we can give them different things like hormone therapy and chemotherapy. So there are a lot of options. So you just work out which one works best. So again, slow 19, hormone therapy, because like we had said initially, a lot of these will be hormone dependent. They don't always stay hormone dependent, but they usually start off such. So we go in and we try to shut off the hormones. We try to see if it helps with suspending the growth of the tumor. And you can use the luteinizing hormone, you can do androgen blockers, and even use estrogen. The androgen and the estrogen are receptor blockers are also both to turn down or counter testosterone, because we're dealing with men specifically here. All right. So looking at luteinizing hormone, you guys already learned about this in breast cancer. There's your leuprolide. Your gonado-releasing hormone comes from your hypothalamus, and it comes down and it starts to suppress the testosterone. And you'll see here, LH and testosterone levels decrease eventually. Initially, what usually ends up happening is that you're telling it to release a lot, because it's an agonist. So it's telling it to produce testosterone. And so you're increasing it so that you can burn it out, essentially. And so then, like when your cells stop responding to insulin, then it's just like similar to that, where you're like burning out the cells. And so eventually you're like now decreasing the testosterone because it just kind of got sick and tired of this agonist coming in, and all the cells start to burn out a bit. So then you become desensitized and your testosterone levels go down. So that's how you can kind of take away that thing that could be potentially feeding that tumor. And then you have the androgen receptor blockers, which we also can call anti-androgens. And that's more considered like an ablative hormone therapy, where it circulates the androgens at the receptor sites and tries to shut things down from there. And then look at our side effects with when you lower testosterone, again, those hot flashes, even breast pain, libido reduction or loss, erectile dysfunction, and gynecomastia. You guys know what that is? You should. Look it up if you don't know. Okay, so the hormone therapies can become refractory, which means that the tumors can then become resistant to those therapies after a few years. So you will keep finding that you're doing your PSAs. Every few years, maybe you're looking to see if you can get another biopsy to see how the cells are doing. Are they advancing? Are they staying static? Or are they looking better? And so usually you're looking at your PSA level initially to figure out if you're responding to the hormone therapy or not. And if you're not, then you have to move on to the next thing. So chemotherapy is going to be a systemic, just like hormones, systemic therapy. And the goal, which is very important to know, is palliation. So palliation is where you're trying to help your patient with their quality of life. So you're trying to increase their quality of life while decreasing their suffering. And so if with that in mind, that's how you as a provider and the patient will like figure out what you're going to do next if it's not responding. So chemotherapy can help with that, but also can create a lot of suffering, chemotherapy. So you figure out what's going to work for the patient and how aggressive do you have to be. And usually knowing the cell types is helpful. Remember whether they're well differentiated or undifferentiated. So here's your jobs, right? Encourage screenings. And you have to have these conversations with them. And it might be really awkward to talk about a digital rectal exam, but you talk about it as if it's the thing that can really help figure out what we're dealing with here. And that, yes, there are side effects to these things, but guess what? Wouldn't it be nice to know definitively if you have a cancer or not? Because then maybe if you don't, then you can go on living your life. And if you do, we might be able to tell you it's like not a big deal, man. What if it's the watchful waiting, that Gleason of, less than 6'7", so that you can do a watchful waiting. And so you can kind of reassure them by knowing more about the systems behind these screenings. And then you can also be really sensitive and caring to these patients and their families. And I would definitely, if one of your patients has had prostate cancer, making sure that you're encouraging them to seek out others who have gone through what they've gone through and get support from them. And especially around the incontinence and the erectile dysfunction, it can be really life-changing for a lot of people. And so you want to make sure that you are suggesting things that will be helpful to them. So that was slow 18, and so is this one, slow 18. When you're nursing these folks, you're trying to get them to adhere to a treatment plan. You're also, especially if they have a lot of bone metastases, trying to manage their pain control and follow through a therapeutic plan of like who they're talking to, who they're getting help with, how are they doing with their feelings, and how are they doing with all of the sensory issues that might be changing for them. I don't necessarily like this one, accept effect of treatment on sexual function. I mean, acceptance is one thing, but there are things we can try. So they don't have to accept it right away. We can, put some referrals in for them and have them talk to people about options. And then making sure they understand how to manage the bowel and bladder function issues that might creep up with these types of treatments. Okay, now we're going to move on to the benign prostate hyperplasia. So remember, benign, not cancerous, prostate, the node, and then hyperplasia. So hyper and cells. So hyper means a lot of cells start growing. So it kind of sounds like a cancer, like a tumor, but it's actually not. It's hyperplastic and it's benign. So we got to talk about the differences between these and how to differentiate. And so on this slide, on the left, you have the normal prostate size. On the right, you have the enlarged prostate size. And you can see that enlarged prostate is impacting the amount of urine that you can actually pool in your bladder. It might even start pushing so hard that it starts to change its ability to come out of the urethra, because you can see the urethra has to go right through it. So you have to be mindful that if someone's having urine retention, that we're looking a little deeper at this, maybe getting that PSA just to make sure. And then also doing a lot of post-void bladder scans, which we'll talk about a little bit more. So the epidemiology of BPH is that you're eventually going to get it. 90% of men 80 and over are going to have this. And if you think about what I said earlier, that they continue to have hormones, specifically testosterone, circulating to their whole life, then that system never gets shut down. So that's, I think, contributes to the cell growth line continuing. It keeps getting information to grow. Men don't stop having semen until something is surgically done or chemically done to shut that off for them. It can affect all men, and you can have BPH with or without prostate cancer, okay? So you should know that. You can have BPH with or without the cancer. Make sure you know that. Okay, so clinical manifestations or symptomology. So you have your lower urinary symptoms, which if you look at this picture, You can see where lower starts. It's from those like ureters, bladder, urethra, and then you have your upper urinary system, which is the upper ureters and then your kidneys. And remember, what we're looking at is making sure that we don't get kidney injury from having all those lower urinary symptoms or potentially upper urinary symptoms. So going through this, you're going to want to know all of these, okay? This is a very important slide. So the lower urinary symptoms, that looks very similar to prostate cancer, right? So trouble initiating urine flow, which also can be called hesitancy, a weak stream, interruptions during the urination, remember, for lack of better words, dribbling after urinary completion, and then signs of retention, which is like, I'm going all night, I'm going all the time during the day, and I have to go. Like, I keep having to go. It's because probably you're never really emptying that bladder because something is blocking your ability to do that. And then you might even have urinary incontinence because the bladder gets so full that when you're not even paying attention, maybe cough or whatever, that urine sneaks out because of pressure. So it's very possible. So you need to know all these. And then upper urinary system, you're looking at your acute urinary retention, bladder infections, bladder stones, hydronephrosis, all the things that we've talked about in the past. If your ureters cannot drain, you may need to put in stents if you're not able to do anything about the hyperplasia of the prostate. So you may even need a urinary diversion. So there's always, options. You just want to think about what those could be and help your patients figure out like what could be best for them. And just so you guys know, for SLO 16, it talks about the tests that are generally done for this. You're definitely going to have a DRE, and that DRE will help you figure out if this is just regular symmetrical prostate that's just enlarged, or if it's hard or nodule, which would then indicate cancer. You're going to do PSAs to help you rule out cancer, because even though the PSAs might be a little elevated, they usually will stay in the same number and not keep getting more elevated. So that's how you can kind of rule out whether this is going in the direction of cancer or not. You're also looking at infection markers to make sure there's not some kind of prostatitis going on there. And then you also can get a UA to rule out infection, to rule out stones, if they're having problems with any of these issues here on the clinical manifestations page. So BPH treatment options, yeah, this is pretty much what we're hoping for, is just watchful waiting, just, active surveillance of their BPH, making sure that they're able to get their urine out of their body and that their kidneys are not getting injured from their inability to get the urine out of their body. Okay, so with nursing management, you get the clinical manifestations are caused by obstruction of urine flow due to enlarged prostate. They also call this a BOO or BOO, which is a bladder outlet obstruction. BOO. And you might have those urinary symptoms, like you might have a temp. You might look at a focused abdominal examination, just seeing, are they really is their bladder big? And if so, have them try and urinate and then go get the bladder scanner and see how much urine is left in there after they've urinated. And it should be less than 250. Usually if it's more than 250, you're going to have to straight cath them. And if this keeps going after you straight cath them 2 or 3 times, it usually depends on the provider, you might have to put a Foley in. And then remember, the Foleys that you have to do with BPH are those ones that have the hard end called the coude, so that you would go in with your Foley with your hard end. It's going to be very uncomfortable for your poor guy. And then you kind of turn it and scoop it around so it can get under the prostate and then up into the bladder. So remember, coude, I think it's C-O-U-D-E-T. You're going to do urinalyses, and then, like I said, you might have to catheterize. And then meds, Flomax. I'm sure you guys have heard of Flomax. So let's go. But remember, one thing I do want to mention here is that if your patient stops urinating, so if your shift is 8 hours or 12 hours, and your patient has not urinated that whole time, you may need to consider it being an emergency. It may, you're definitely going to bladder scan. Are they making urine or not making urine? What are their renal numbers? Look at that BUN, that creat, and figure out, okay, so no, I don't see a lot of urine, so that we're not in trouble where we could actually have damage to the bladder. But if they are retaining urine because their kidneys are working, that's when we need to make sure that we're helping them decompress by having that catheterization. And we have to watch that. Every patient you have, you need to know what their urine output is. And initially, you might not even have to worry about it, right? Like, oh, okay, I know he's peeing, that's fine. So I can take that off my mental plate. But these other ones, I'm keeping an eye on them because I haven't seen much. And then maybe like they'll pee once and they'll be like 800, and you're like, oh, shoot, okay, good job. So I don't have to worry about you. I guess you just don't pee as often. And that's good information to pass on in a handoff, right? Like, they don't pee very often, and when they do, wow, I can't believe how much urine they can hold on to. That sounds very uncomfortable to me, but some people live like that. Okay, so let's talk about Flomax. So Flomax, aka Tamsulosin, is an alpha androgen antagonist, and its action or its MOA is to relax. So Flomax, relax. Flomax, relax. Okay, you need to know this one. This is Flow 17, by the way. And what it does is it uses, it blocks the norepinephrine, and so that the smooth muscle kind of relaxes instead of being as tight and taut as it usually is. But they do have a lot of side effects. So with these folks, they might try to get up and like get woozy and dizzy because they have orthostatic hypotension, which means we may need to advocate to have their dosing lessened, or it might not be the right med for them, especially if it's a chronic issue that keeps happening to them. Because orthostatic hypotension, maybe they'll fall, maybe they'll hit their head. There could create more problems than you're solving if this is a really bad issue with their side effect profile for this medication. And then you want to make sure that they feel good before they start driving behind a car, because you don't want them having, change in blood pressure as soon as they get behind a wheel. That would be bad news bears. You're going to decrease the dosage if they have liver or renal impairment. So it's always something to remember as the nurse, to back up your provider by letting them know, hey, you might have ordered too much. I don't think they need that much because I'm getting a lot of low BPs for them. So you can call and do an S-bar and try and, rectify the situation. It could interfere with a cataract surgery. Just an FYI, it can cause something called floppy iris syndrome. Look it up. And then this is important because I know a lot of our patients are on warfarin. It could potentially interact with warfarin. And then, of course, Viagra, anything that lowers the blood pressure. Viagra probably should not be taken while they're taking that. And that's an open conversation you need to have, especially if you're sending them home on a new medication and maybe they got Viagra from another country and they use it, for fun and not for pulmonary hypertension. Then you want to have that conversation with them because it's really important. It could potentially kill them if their blood pressure drops too much. And just as an FYI, you might also hear of finasteride, which is also called Proscar. That's the other one we'll give someone with BPH, and that's to shrink the prostate, and then the Flomax to relax the urethra so things can get through it. Okay? All right, so nursing eval. What we're looking for with our treatments is less urinary retention, a stronger stream, and less having to go at night. Okay? And then still educate them on the things that they need to be mindful of, like limiting fluids after like dinner time, limiting diuretics, limiting the amount of bladder irritants. You're going to want to tell them like, really spicy food can be a bladder irritant, or anything else that they've noticed is an irritant for them. And you're going to want to make sure that they are compliant with their medications, okay? That's the only way to keep things going and to avoid all those complications that can happen should you not be able to get urine out of your body. And make sure they go to their follow-ups and talk to them about their surgical options and then what happens post-surgical for them. And make sure they know that sometimes part of a BPH treatment plan is that they may have to learn how to self-catheterize, or they may have to have a chronic indwelling Foley, or we call it a chronic Foley, which, opens them up to a lot of other problems, right? You have that CODI issue. And this is just kind of FYI, but it's something that you can mention. And then here's a way that we can go in and slow 19, do some cleaning out, if you will. So it's a transurethral, so through the urethra, out chihuahua, resection of the prostate. So they go in and they try to clean out as much of the cells and tissue as possible. And you can see the before and after here. And after something like that, we may have them on what's called a continuous 3-way Foley irrigation, or that CBI that I mentioned. And this is slow number 20. So you guys are going to have to do something. You're going to have to figure out how to calculate urinary output for a CBI. So I'm not going to tell you. I'm going to have you guys figure it out. And it's part of the case study that you're going to be doing after this lecture anyway. So let's talk about a CBI. What is it? So you hang this big old bag of fluid, usually like 4,000 mils, like 4 liters or something. And it's big. You might even need help like getting it up there onto the IV pole, getting it up there. And then you're going to connect it to where it actually goes into you'll have like one of those little like rolly ball ways of controlling the flow. And it goes in, and then the Foley bag will then collect what comes out. And after a TERP, you are expecting some blood, right? You're expecting it to be kind of a light pink color. It's very important to know. You're expecting that. However, if it intensifies and gets more red, then you may want to turn up the rolly ball so that you're getting a little bit faster to see if you can get the light pink color, which then in turn helps those cells in the prostate, in the urethra, whatever's been traumatized by that TERP. It's trying to get it to hasten recovery, hasten healing. So if it's red, turn it up. Turn up if red, turn down if clear. Yeah, that makes sense. So turn it up if it's red, and then maybe turn it down if it's nice and clear, because you want to make sure you're not just like whoosh. So all you see is the irrigant, but you do want to see like that it goes from pink to clear. And if that's the way it's happening and it's been a few days, then you know you're on the right track. Now, if your irrigant is not coming out, and and by the way, these are patients that you're going to have to look at every 30 minutes, because they're going to be filling that bag up very, very quickly. And you're going to need to have a couple people on your team helping you go in and document and dump the contents of the drainage bag. And if you notice that you looked at 3 p.m. and they had 400, cool. And then you go and you get report on other people. And now you come back and you look and you see that it's still only 400, you're like, it's been 30 minutes. That thing came out. I wonder if something is blocking the outlet, in which case it could be a clot. And then what you'll do is that you'll actually take a syringe, usually normal saline, and you'll actually push it to see if maybe the outlet is covered by the clots. And if you can push more irrigant in, maybe you can pull off those clots and then they can slip out and come out. So this is something you have to keep a very close eye on. So any CBI patient that you get, you have to keep a very close eye. And if you're draining them too much, you might get some spasms. And so you might need to turn it down a little bit, but then you have to use the color of the urine and the output to help you figure out if you should go up or down on your clamping. And then if they do have to go home with any of this, you'll teach them how to use a leg bag for their Foley cath, because they may have to have a chronic Foley for a little while. All right, so you're going to look up how to calculate output, and I also want you to know how to monitor for blood clots that are blocking the outflow. So both things that I talked about. And last, you are going to have probably some issues with erectile dysfunction after a TURP or a TERP. It can be permanent, so you're going to probably need to give them referrals to support groups, urology, whatever they need, psychiatry, whatever they need to help them get through this and to maybe either accept or find solutions to these issues. Libido usually is not affected, which is maybe even more frustrating, is because they have sexual desire, they just can't perform. And so again, those referrals will be really important in being able to have these open conversations with them and following up with those specialists. So my recommendation is to go and look at your unfolding case study, prostate cancer. So this is a case study that we're going to do, and I want you guys to go through it and get it done. It's kind of like a step-by-step of like a shift happening, and I'd like you guys to have this done before you come see me. And the other thing that could potentially be helpful, especially if you're working in groups, is coming up with a compare and contrast. Where's my camera? Here it is. Compare and contrast BPH and prostate cancer. You can see I left it blank because I didn't want to give everything away, but we'll also probably try and do this together, especially during our prostate cancer case study. So make sure that gets done. Thank you for watching. I'm sorry if I was a little inappropriate at times, but being able to have these conversations, sexual conversations with patients in a professional manner is really important. Me being playful in my teachings to you, trying to loosen the mood because this is some bummer stuff here. I don't necessarily act like that with my patients, but I do try to create that open, safe space for them to discuss, like, how will an erectile dysfunction affect you? Are you afraid that your partner might leave you because you can't perform? Like, these are really big issues for some couples. So making sure that you know what your referrals are and how to give them that safe space to talk about these things. Some of their deepest, darkest fears could be related to these issues. Being incontinent makes you feel like an old person. Now you have to wear a diaper. You know, this is serious. So as much as I play around and say a little inappropriate things while teaching this, ultimately, when I'm face to face with patients, I'm making sure that I'm creating that safe space, non-judgmental space for them. All right. Thanks, guys.